Hello, welcome to sqadia.com. And have you ever seen a patient with generalized aches and pains? Have you ever wondered what it could be? Anything. Coming to our topic is crystalline deposition disorders, and there is a lot of discussion regarding decreased amount of calcium in our body, and you have seen it on the news as well. But have you ever wondered what happens when there is an increased deposition of calcium or any calcium salt? Well, calcium pyrophosphate crystal associated arthropathy can occur in our body. In this, we'll be going through the pathology, cartilage calcification, and how this acute CPP arthritis occurs, and then what is actually associated a complicated form with osteoarthritis. CPPD or calcium pyrophosphate deposition disorder is usually the consequence of cartilage changes which results in the deposition of calcium pyrophosphate crystals. And you can appreciate over here that these once get accumulated, they can affect the small joints of the hand. It's associated with aging, degeneration, enzymatic degradation, and traumatic. Now, this is a diagram which is showing a pathology or in pyrophosphate is probably generated in the abnormal cartilage by enzyme activity at the chondrocyte surface, combining with the calcium ions in the matrix where the crystal nucleation occurs on the collagen fibers. What happens is if there's a trauma, or for example there is aging process which is going on, there's increased wear and tear of the body as person ages, there is a loss of normal regulatory mechanisms. Chondrocyte starts to hypertrophy, then there is release of certain mediators which actually given from ANKH mediated pathway, they actually results in increased basic calcium phosphates and crystal deposition, or there could be matrix saturation with EPPI leading to calcium pyrophosphate crystal depositions. Now once they deposit there is an inflammatory reaction of the synovium. This synovial inflammation releases metalloproteinases, collagenases, and proteolytic enzymes, starts to degrade the cartilage, and this further actually this cartilage enters into a vicious cycle that increased degradation of cartilage occurs, which further produces these enzymes and then further degrade the cartilage. And if once the deposition has occurred over here, then there is increased interleukin formation as well, inflammatory lysosomes cascades actually starts, and they increase the degradation process of the cartilage which was initially started by the calcium pyrophosphate crystalline deposition. Now what actually happens is how this calcification takes place. It's also called as chondrocalcinosis. Chondro is cartilage and calcinosis is calcium deposition, referring to the appearance of calcification usually due to calcium pyrophosphate crystal deposition in the cartilage. If you see this diagram over here, this is showing an AP view of the knee, which is joint, and there's reduced joint space on the medial side. Although there's joint space appears to be normal on the lateral side, but if you see over here, there's specks of white which can be seen inside the joint. These are actually the calcium deposition in the cartilage, and which has actually started erosion, and there's mild degree of sclerosis over the lateral femoral condyle, which actually shows that the degradation process has actually started from the hair, and eventually once the degradation would occur, then there would be collapse leading to reduced joint space and varus deformity of the knee. If you see it over here, it's very this is showing actually an x-ray of a wrist joint involved with distal radius ulna, carpal bones, and some amount of metacarpals. Although this is actually a pent hand, not very clearly visible, but if you see it over here, there's a slight degree of calcium deposition in the first interphalangeal joint, which is actually outside the joint. Although the joint this moment appears to be intact, but there is some degree of deposition which is actually started in the cartilage of the first interphalangeal space. It's generally seen in fibrocartilage as cloudy, irregular opacities. Menisci of the knee could be affected. Triangular fibrocartilage complex of the wrist joint could be affected. as you can appreciate it over here. Now this is where usually the TFCC complex is, and if you can see a thin white line over here in the joint between the ulna and trichotrium and pisiform, this is the point where usually the TFCC is present, and once the deposition in the TFCC complex takes place, this appears like this, a thin specks of whitish dots and line which can be appreciated. It could be even present in the pubic symphysis and intervertebral discs, where it also, once the calcium starts to deposit, there actually increased whitish appearance, and a thin white line or specks of the calcium can be seen in these areas. Now coming to the cartilage calcification. Cartilage calcification is strongly associated with age, prevalence rising from 10 to 15% in those aged 65 to 75, and 36% in older than 85. So actually CPPD is highly associated with age. If there is older patients, usually have some degree of calcium pyrophosphate deposition in their joints. What are the other metabolic conditions which could be associated with CPPD? These are diabetes mellitus, hypothyroidism, uremia, hemochromatosis, hypomagnesemia, and Wilson disease, which actually there is high amount of copper in Wilson. In hemochromatosis, there is increased amount of iron deposition. In case if there is an acute CPP arthritis, that is acutely over a very short period, there is a lot of crystal pyrophosphate or calcium pyrophosphate crystal deposition. This results in acute pseudo-gout. Although their inflammation presents a kind of a picture of gout, that there is acute swelling, there's erythema, reddishness of the skin, there is swelling in nodular appearance of the hand and the knee and joints. But if you look closely, this is usually the calcium pyrophosphate rather than the gout. If you see these arrows again around the fibrocartilage in TFCC, there is some degree of deposition over here, which can be seen on this diagram as well. And then this, if you see the second metatarsophalangeal joint over here, there is some degree of deposition in acute CPP arthritis. CPP crystal may trigger an acute inflammatory reaction within the joint. It can cause either traumatic trauma, intercurrent medical illness, surgery, and blood transfusion. So what are the differences between acute gout and acute pseudo-gout? Differentiation from gout can be very difficult, especially if the first metatarsophalangeal joint or pseudopodagra is involved. If a patient comes to you with 80 plus years age and there is swelling of the first metatarsal, it is very highly unlikely that patient does not have a gout. But then still the patient could be having inflammation or swelling due to calcium pyrophosphate deposition. And how would we come to know? The most important criteria, most specific, is basically the in polarized light. If you see the synovial aspirate of the joint, that if it is due to gout or hyperuricemia, the monosodium urate crystal will show the bifringence. But in case of calcium pyrophosphate, they will not be showing the bifringence. And in normal light and white light, if you view them under high power microscopes, these monosodium urate crystal will be needle shaped, while in the case of calcium pyrophosphate will be in case of a large oblongate shape. Acute CPP tends to have a slightly less acute onset, attacks last longer than 7 to 10 days, and pain may be marginally less severe than the gout. How do we treat the calcium pyrophosphate arthritis? Treatment includes rest, analgesia, because the patient is in pain, so you have to give NSAID so that the patient is relieved of its symptoms. Then aspiration is basically done to, first of all, the diagnosis, so that the confirmation of the diagnosis can be made. Then injection of the steroids, and occasionally high dose colchicine may be needed. Colchicine, although is classically for gout, but high doses of colchicine can also be given acute calcium pyrophosphate crystal deposition as well. What if a patient has actually osteoarthritis associated with CPPD? Now, classical osteoarthritis involves multiple joints. There's a history and then there is age, but sometimes these symptoms very much overlap. Usually osteoarthritis also occurs at old age. Similarly, the CPVD incidence also increases with old age. But usually in calcium pyrophosphate, it's mainly involves the metacarpophalangeal joints. If these areas and radiocapitular or ulnocapitular joints in the where the TFCC complex is. But in case of osteoarthritis, mostly the joints involved are interphalangeal joints, especially the distal interphalangeal joints. The presence of CPP crystals appears to moderate the development of osteoarthritis. Characteristically, there is hypertrophic reaction with marked osteophyte formation. These are usual features of pain, stiffness, swelling, joint crepitus, and loss of movement. Synovitis is more obvious than in osteoarthritis without CPPT. Now this is again showing an osteoarthritis patient who has also a CPPD, and if you see, this is a lateral the X-ray of knee joint. If you see, there's a lot of osteophyte formation, there's high degree of sclerosis, and this is probably the calcium crystals have deposited outside in the bony area, and this may be inside the joint, resulting in a formation of a loose body. There is marked reduction of joint space. There is another loose body forming over here inside the joint is getting deposited, and this may be dislodged into the joint. There is reduced patellofemoral joint space. There is reduced tibiofemoral joint space as well. The characteristic X-ray features arise from combination of intra-articular and peri-articular calcification and osteoarthritis. In advanced cases, joint destruction may mark and formation of loose body may take place. And once this happens, then once we have diagnosed the patient with CPPD, we need to treat it. Now, what actually happens is, what are the surgical options in CPPD? That depends upon how much the degree of destruction of joints. In case if this kind of a joint comes up and the knee is markedly deformed and there's a lot of degree of osteoarthritis, probably the surgical option would be total knee replacement. But then it has to be carefully titrated, because in these patients there could be other comorbids as well, and then what kind of implant has to be used, especially in these patients, that is also needs to be considered. Thank you very much. Keep watching sqadia.com.